All right, so this first lesson is on the management of clients with coronary vascular disorders. So here are the lesson outcomes. I'm not going to read through those. You can read through them yourself. So if you need to use them to help to guide your study, they're also listed on the lesson plan. So the first part of this lesson, we're going to talk about coronary atherosclerosis. So we've seen this slide before, but I just want to re-emphasize it. So atherosclerosis is the buildup of fibrin deposits, or not fibrin deposits, I'm sorry, lipid deposits and fibrin tissue covering kind of over the fibrin gets into part of the artery. We'll talk about that more on the next slide. So this can happen anywhere in any vessel in the body. So if it happens in the periphery, like the legs, the arms, the abdominal aorta, the carotid arteries, or up in the brain, that's considered peripheral arterial disease or peripheral vascular disease. So coronary artery disease is when it happens in the coronary arteries. So if you follow down the right side to the blue boxes there, so patients can have chronic coronary artery disease where they have plaque buildup, they've got lipids, which becomes plaque in their coronary arteries, but not to the point where it's totally occluded. So some people may be totally asymptomatic, some of them are completely stable, but it's when that stable plaque becomes unstable, which can lead to myocardial infarction. So myocardial infarction and unstable angina are the two components of acute coronary syndrome, which we're going to talk about those later on in this lesson. So in the United States, heart disease is very, very prevalent. 1 in 4 deaths, which is a lot. So it's the leading cause of death for both men and women, but more than half of the deaths were in men, and usually are. And it is the most coronary heart disease or coronary artery disease kills over 370,000 people annually. So the next bullet point there says that over 735,000 Americans have a heart attack every year. So roughly half of those people that have a heart attack go on to survive it, which is a great thing, that we have made great advances in coronary vascular treatment, and so that will only continue to improve. So thankfully, not everybody who has a heart attack dies from that. But it is the most prevalent type of cardiovascular disease, even more so than hypertension in the United States. So, the United States is very multicultural, so this list is not all-inclusive, but it does show you that non-Hispanic whites and blacks are pretty equal as far as coronary artery disease. The disease process goes. Asian or Pacific Islanders are not far behind, and then American Indians and Alaskan Natives are even a little bit farther down. But that doesn't mean that there aren't other nationalities or ethnic groups that don't have a high incidence of coronary artery disease. So for example, people that are from Pakistan or India have a very high rate of coronary vascular disease because of there's a strong hereditary component to that. So just keep in mind, this is not an all-inclusive list. So this slide I think is very interesting. It's very telling. It shows that here in the southeastern United States we have a very high incidence of coronary artery disease, and a lot of that, I would say most of that, is our lifestyle here in the South. We don't always get a lot of exercise, we don't eat healthy, and if you look at some of these areas, like I've been to the Appalachian Mountains in Kentucky on a mission trip when I was in nursing school before, years ago, and even though it was a very rural area, the people didn't eat a lot of vegetables, and they have a very high incidence of coronary artery disease. So if the places out west where you see the darker red, those are usually Indian reservations. But just because we live in an area where we have good weather, we could get out, we could exercise, we could have a garden, we don't always do it, and so our lifestyle is what leads us to having more coronary artery disease. So here's kind of a description of the pathophysiology of it. So the top diagram, this is like a half of a cross section. So in the top one, the artery is nice and smooth. You can see the different layers of the artery. So what happens is that you have some kind of insult to your arteries, whether it's from smoking, from being overweight, from having high blood pressure. So somewhere there's some kind of insult. And what happens is the fat, the lipid deposit, so there's lipids, free lipids, triglycerides, and lipids that are floating through your body, and they tend to stick to these areas of injury. And then they kind of become part of that injury wall, or part of that, the intima there, the white part, of the vessel wall. So that's where you, in letter C there, see how it becomes part of it, and then you get this fibrous tissue that kind of covers over that. And then it continues to grow, and you get some little fatty streaks inside the artery until the artery is almost completely occluded. And then what evidence has shown is that some of that plaque inside that artery wall becomes unstable, and it breaks loose, and that's like an injury to the inside of the artery wall. And so that inflammatory response happens where the platelets rush to the site and they start forming a clot, and that's what leads to the total occlusion. So this is just a different slide here, just showing you the progression from the left side where it's completely open to the right side where it's almost completely narrowed and the blood flow can't get through. So on the right-hand side is a picture from a cardiac catheterization where they inject the IV contrast into the arteries there, not IV contrast, but the it's actually injected straight to the arteries. So I've pointed the arrow there where you can see where the narrowing begins there. There's also an even tighter narrowing up toward the top right-hand side of the page. You can kind of see where it's a dark, kind of like a string there between two larger areas of the vessel. So this, and there's many other areas here where anywhere it looks like there's a chunk taken out of it or sausage link or something like that, that's where plaque is. They should be completely smooth down both sides. And then also the vessel that's coming down kind of from the left side, from the top to the bottom, it looks kind of like a corkscrew down at the bottom. That's what you see when patients have hypertension. Kind of makes the arteries look kind of corkscrew like that. And that every time that twists like that, that's another place where that where the lipids can accumulate and become part of the artery wall. So this is a diagram of the coronary artery. So you have two main coronary arteries. One comes off, well, they both come off of the aorta right outside the aortic valve. So again, when the aortic valve is open, the flaps of the aortic valve partially cover those openings to the coronary artery. So heart rhythms that are faster, that will diminish the blood flow to the coronary artery. So if you have somebody that has blockage and they have diminished blood flow, then they are at greater risk for their having chest pain and having a myocardial infarction. So as you can see, there's main arteries, and then there's little branches that come off of them. So if somebody has blockage down at the tip of one of those little branches, then it won't, that branch doesn't feed as much heart muscle as then if the patient had blockage in, say, the left main coronary artery. So that's considered, if somebody has a blockage there, that's considered the widowmaker, because it blocks off all of the blood flow to all that muscle tissue of the left ventricle downstream, also probably the left atrium as well. And so that's a large part of the heart itself, and so in the main pumping chamber. So the higher up and the more the larger the vessel is, if there's a blockage in a large vessel closer to the aorta, then it can do more damage than if it's smaller and further down in the heart. So the symptoms of coronary artery disease are caused by ischemia to the myocardial muscle, and this ischemia results from two processes. So one is the increased demand or need for oxygen. So this would occur like for instance, if you were exercising or eating a big meal or stressed or something like that. So again, for you, if you went out and ran 10 miles, that wouldn't probably bother you. But for your patients who are compromised in other ways, turning over in the bed or walking down the hall or getting up to the bathroom, produces a demand in their need for oxygen. And then the other process is when there's a decrease in the supply of oxygen to the heart muscle. So this might occur with a rhythm that's faster, if there's a drop in the cardiac output, or if the patient's anemic, or if there's blockage in their coronary artery. So if you have those two combined, then that's not a good situation. We've already kind of talked about the location and the degree of the vessel obstruction, so the symptoms and the complications are related to that. And when the vessel becomes occluded, the heart muscle starts to become cyanotic, starts to die within the first 10 seconds of that total occlusion. So it's so important to get that patient early access to a healthcare facility where that artery can be opened up and the blood flow can be reestablished. So when there's occlusion, that leads to anaerobic metabolism, which leads to lactic acid production, which leads to the nerve fiber pain, which leads to the pain of having lack of blood flow. So you want to always, always, always consider chest pain a serious priority until it's ruled out that or until they say, okay, this is acute coronary syndrome or myocardial infarction, or until they say, no, this is not. So, I've put this diagram here. Chest pain can come in a lot of forms. We're going to talk more about that. But you can kind of see it can be substernal, it can be back, it can be left jaw. One time in the cath lab, we cathed a woman who was of a certain ethnicity that's very prone to coronary artery disease, and her only complaint was tooth pain. But fortunately, the physician was very astute, and he thought, I wonder if this is her heart. So he did some cardiac biomarkers, and sure enough, they came back positive. And we cathed her, and we sent her straight for bypass surgery. Her blockages were so bad. And I think she was like in her late 30s. So we used to joke that any kind of pain or discomfort from the waist up deserved a cardiac cath to rule out coronary artery disease. So use your assessment skills. Be very astute. If something doesn't seem quite right, make sure you let somebody know. So there are risk factors for coronary artery disease, so that some we can't help. So we can't help the family that we were born into. So if you have a first-degree relative that has coronary artery disease or had it, so by first-degree relative we mean mother, father, brothers, sisters, grandparents, something like that. And if that person was 55 years or younger for males or 65 for women. And then also increasing age. So this is different from having a relative. This is everybody as we get older are at more risk. So obviously the men are at risk earlier, and they develop it about 10 years earlier than women do, because women are kind of protected by the estrogen that they produce until they go through menopause. And then we've already talked about race. So the things that you can modify are your diet. So keep your lipids under control. If you have a problem, even if some people eat a healthy diet, they still have hyperlipidemia. So there are medications for that, and hypertriglyceridemia. So there's medications for that as well. Cigarette smoking, just stop. Don't use any kind of tobacco. Keep your blood pressure under control. Keep your diabetes under control. Doesn't mean if you have hypertension or if you're diabetic that you're going to have a myocardial infarction, but if they're out of control, your chances are greater. Metabolic syndrome we're going to talk about on the next slide, but being obese and physically inactive are very strong risk factors, but those can be modified by losing weight and being active. And then metabolic syndrome is fairly new. They found that through research that if a person has 3 or more of these things, that they are at greater risk for developing coronary artery disease. So the first one is insulin resistance, so having a fasting plasma glucose of greater than 100, which is not a lot. Central obesity, where you carry the weight around your waist. So these are the people that are apple-shaped as opposed to pear-shaped. That doesn't mean that people that carry their weight around their hips or their thighs can't develop coronary artery disease, but typically people that have it around their waist, anytime you have extra adipose tissue in the body, that adipose tissue has to have blood supply. So it's stealing blood supply from the vital organs like the heart and the lungs, the brain. So that is that's why carrying that weight around your waist where it's not getting the blood supply to the vital organs is so important. And then having high triglycerides, and HDL is that good cholesterol that kind of goes through the arteries, kind of eating up the bad cholesterol, so that you want higher. So unfortunately, the HDL is not something that you can modify too much. It has a very strong hereditary component to it, but you can also modify it somewhat through diet and exercise. Keeping your blood pressure under 130 over 85, which is not high at all. Keeping your pro-inflammatory state down, so it's not just because of some kind of disease process or injury that you might have an inflammatory state, but also being overweight, being stressed, not getting enough sleep, those things, and not eating the right diet, those things can also cause a pro-inflammatory state. And then high fibrinogen level is a fairly new thing added to this metabolic syndrome. So any of these 3 or more can predispose somebody to having coronary artery disease.